Okay, good evening everyone and welcome to the use of external fixation and foot reconstructive surgery webinar with Dr. James Wang. Before we start, let's take a moment and ensure that everyone is ready and familiar with the webinar control panel. You will have the ability to submit questions using a chat box. If it does not appear on the right-hand side of your screen right now, please select the button that says Chat on the top right of your screen. Once your chat box has appeared, please type your question into the white chat box directly to the left of the send button. You may ask questions during the lecture in the chat box, and Dr. Wang will address them throughout the webinar. So without further ado, Dr. Wang, the floor is yours.
Wow, you sound pretty formal there, Jared.
Thank you.
How's everybody tonight? So basically it's meant to be a very informal process. Feel free to type a question in. So you see I hope everyone can see the slide. If you don't, just type in and we'll try to rectify the situation. Hopefully everyone can hear me okay. So basically we're just going to talk about more mini rail or mini external fixation in foot reconstructive surgery. We'll progress to the next slide. I'm very fortunate that the majority of my practice is in a large multi-specialty orthopedic group in Marina Del Rey outside of Los Angeles, California. External fixation in my practice I think truly benefits my patients, and I'll explain that in a few minutes. Some background, this is my 20th year of practice. It's hard to believe that time flies so quickly. I was very fortunate that my residency training was a 4-year program in Philadelphia at the Presby Medical Center, University of Pennsylvania. And at that time, our interest was really more focused on AO and internal fixation. And the things that we were doing at that time, to me, really were kind of, obviously I was a student and a resident and learning how to do things. But it was more along the lines of these large incisions, multiple screws and plates, and we'd immobilize these patients for extended periods of time. We actually found that we were getting wound dehiscence, stiffness and arthrosis in a lot of these patients post-operatively, not to mention the muscle atrophy and the multiple cast changes. So at that time it was kind of more of the thought of, can we come up with something that might be a little more different? I'm not going to use the word revolutionary, but just try to get our patients to be more active. I'd ask a lot of my attendings, why do we wait 6 weeks till we weight bear these patients or do range of motion? And that they'd always say, well, that's the way it is, and that's the way we teach, and that's what you'll do. So my goal was to try to come up with something a little more different. Several of us throughout the country and the world are utilizing external fixation. I will tell you that we really give our patients the options of explaining what procedures they might need and giving them the different types of fixation that they can choose from, whether it be internal, a combination of internal and external, or just external fixation. And you'd be quite surprised at how many of these patients will actually choose to go with the external route, which I'll cover in a few minutes. So I will just tell you that this is actually a picture of what appears to be a shark in a wave, and it actually is a thresher shark in a wave that is actually surfing. And I apologize for the blurriness of the picture, but I took a picture of this with my iPhone because it was a newspaper picture article. And my biggest fear is sharks because I'm in the ocean probably 4 or 5 days a week, and I will tell you that a lot of people are afraid of external fixation from the points of, they all get infected, patients hate them, they're painful, and I think a lot of that is just the fear of the unknown of, number one, maybe not being exposed to it, maybe not being exposed to the type of fixators, and more importantly, the clinical indications that you could actually use. This is really what the genesis that we probably came up with using external fixation. You can read this slide much faster than I can speak through it, but I'll go through the bullet points. You'll find that we're doing multiple things. We're doing fusions, or we're doing things where we can compress or distract, and we're doing range of motion simultaneously. We are doing extremely early weight bearing. We started to do weight bearing at 5 weeks, and 4 weeks, and 3 weeks, then 2 weeks. And very rarely are patients not walking day number 1. The only reason they're not standing or walking day number 1 is because a lot of our patients now are getting regional blocks by our anesthesia team, whether that be saphenous popliteal blocks or femoral nerve blocks. So because of the insensate foot or leg or motor block, these patients aren't able to walk, and that's the reason why I've pulled back a little bit and say they're not walking day number 1. I still feel that it's the best compression of any fixation purely because it's parallel to the long axis of the foot, and your screws are perpendicular to the long axis of the foot. And it's hard to do that with screws or plates. And more importantly, you can adjust its compression, and we'll get into that in a little bit. The next bullet point's MIS, or minimal incisional surgery. It's a very popular thing in the spine field right now. We actually find our incisions, you can actually judge somebody, whether it's through a frame or a mini rail, of their experience by how small their incisions are. And when you first start to do these, you'll start to have very large incisions, and you'll start to think, gosh, why did I make that incision so large when I really didn't need it to be that large to expose everything? And that's kind of more of our training from utilizing screws and plates. So I would tell you, start small, and your incisions will actually become much smaller than you actually think you'll need to. Biological footprint is a phrase coined by a very good friend of mine who's an orthopedic deformity and pediatric surgeon in Liverpool, England. Basically not leaving things behind. We're leaving screws and plates behind. We all know when we've had to remove painful retained internal fixation, the scar on top of the foot or under the skin contracts. It's a pain in the butt to take out these screws and plates. So it is something to think about, to leave all this fixation behind, more importantly in the insensate foot. And you can really actually visualize the amount of compression, and we'll get into that when you compress the screws, 2 screws usually on one side of your deformity or arthrodesis site or joint itself. You can actually see these screws start to bend away or genuflect away from your area, which can identify how much compression you're applying on the area. And for those of us in private practice, we find that you can actually bill for the application a CPT code and remove these with a CPT code. And we're sometimes finding that our reimbursement from the insurance companies almost matches the reimbursement for the actual procedure. So it's just something to think about. This is a slide that's a very ancient slide. It's probably 36 years old now, and it just talks about the resting blood flow in the adult tibia compared to resting versus functional loading. And I have taken that to compare it to non-weight bearing in a short leg cast to walking, and we can argue whether you're functionally loading with a mini rail on or a circular frame, but it shows that it's greater than 6 times more blood flow when you can actually weight bear or walk your patients. And we're finding that to be an extremely crucial point in getting our patients to heal much faster than stated times when comparing to internal fixation. So this is the small bone innovation mini rail system. It's a one self-contained tray that you'll find, and I will actually go through some clinical cases. So this is a pediatric patient, 11-year-old female, who, if you can see where the cursor has a displaced physeal fracture of the 3rd metatarsal. And what also is evident is a slightly fractured and displaced 4th physeal fracture also on this foot. So once again, as you know, with all of us who are dealing with pediatric patients, we always use the example, it's comparable to a vet where you have to talk to the parents of the dog or cat, and you explain to the parents the options, and you think about physeal injuries. Do you want to put something that crosses the physeal joint if you used an intramedullary wire? And our goals were to bridge the physeal joint to actually relocate the distal fragment of the 3rd metatarsal The thinking was also to why not utilize the intermetatarsal ligament to hopefully pull the fourth metatarsal over, and that's what we accomplished with this mini fixator system. You very rarely have to make an incision. You can do this closed. One of the points that I probably utilize, mostly in my practice are utilizing 25 or 27 gauge hypodermic needles. And we do that for multiple things. We find that it helps us with our screw placement. You can actually place the needles through the brackets to help identify, and I'll show you that in later clinical cases, the angle and more importantly the anatomical level of where you want to be. Instead of opening up the wound or the foot to expose everything, it allows you the chance to what I call cheat or figure out the angulation and the level of your screw placement. This is done. The patient can weight bear right away. There was not a regional block on this, just a proximal block, not a saphenous or popliteal block. Usually we don't use a tourniquet on this because there's no incision. And patient's placed in a post-op shoe. Patient usually can bathe the same day or next day depending on the time of your case. And this is just the post-op of this patient afterwards. Moving on, probably one of the more common cases that the origin of mini external fixators came about was for breaking metatarsia, or more commonly the short fourth metatarsal. And this, you'll actually see a clinical case where we're using the hypodermic needle. These are two 25 gauge needles trying to identify the base of the fourth metatarsal, and it allows us to do it without a tourniquet, and allows us to identify the level of where we want to be versus laying a freer elevator or some type of radio-opaque instrument on the foot itself. And what we're also doing here is no incision is made. We're actually using the hypodermic needles to actually identify the levels of the medial and lateral borders of the distal aspect of the fourth metatarsal head. This is not what we're using right now, but it's still a lot of people will utilize in intramedullary Kirschner wire through the digit across the metatarsal phalangeal joint into the head of the metatarsal. So therefore, when you actually will lengthen the metatarsal, you'll actually lengthen the whole ray or the metatarsal and the toe at the same time. And I'll get into that in a few minutes. So our goals are to utilize the hypodermic needles because we're not opening this up until we make our osteotomy or coracotomy. And so what you'll find is an example, the needles are out. We make our coracotomy utilizing through a small incision dorsally, and then actually retracting the extensor tendon complex, utilizing a sagittal saw, or if your choice is to fenestrate the bone, utilizing a small drill bit or Kirschner wire and finishing it with an osteotome. Usually in the metatarsals, we just utilize a sagittal saw in that case. And then the most important thing is to make sure you're through and through on the your coracotomy. You can extend it intraoperatively to make sure you've gapped your osteotomy, or you can actually take off the fixator and rotate the fragments. So the usual rule of thumb is 7 days of reapproximation and anywhere from 2 to 4 quarter turns a day. I think it really depends on your comfort level. When you first start to do distractions, you might want to start 2 quarter turns a day, up to 4 quarter turns a day. And that's what you'll start to see where the cursor is, some signs of regenerate or callus in the area. But obviously it won't consolidate until you stop your distraction itself. So the only problem that we were getting with this is you'll start to see some impingement or impaction at the metatarsal phalangeal joint. There's still quite a lot of people that still do it this way and it's still acceptable. Once you start stopping, you'll start to see further regenerate fill in this area. One thing of note is that you'll notice the proximal placement of the pins. One is trying to get into the base and one is into the cuboid. which actually bridges that joint area and allows you to actually have more leverage to actually distract the area. And then you'll start to see the excursion of the metatarsal moving distally. And I think probably the more important thing with your lesser metatarsal's distraction is not just evaluating the radiographic parabola, but more importantly, the weight-bearing parabola. And we find if you palpate or do a pressure reading on the metatarsals, it's really the weight-bearing parabola which is more important. A lot of these, we actually try to lengthen them a little longer because the metatarsal heads are much smaller than the adjacent metatarsal heads. And we find, excuse me, from a functional point of view, that a little more length on these than what would appear to be radiographic on your parabola is a much more better functional result. And so you start to see the regenerate. This actual pin is not into the base, but ideally we try to place one into the base here and one into the cuboid. And you'll start to see the further regenerate area, and this is post-removal. One thing that we will do on removal is take off the 4 screws in the fixator, and we also try to manipulate the metatarsal phalangeal joint at the same time. But you can see where down the road this becomes more of a problem with the narrowing of the 4th metatarsal phalangeal joint. So that's one reason not to try to do it this way. This is a clinical picture of the patient preoperatively and the picture of the patient postoperatively. Sorry, I have to get a drink of water. And moving on to hallux valgus. My theory on hallux valgus, if I want to use a theory, or my protocol, is that you have a straight metatarsal. These deformities are comparable to a leaning tower at Pisa. The metatarsal is straight. Your deformity usually is more into the metatarsal medial cuneiform joint where the arrow is. And if you think about the leaning tower at Pisa, if you were going to rectify it, it is comparable to a left hallux valgus deformity. The tower is straight, but obviously at the tower ground interface is where the deformity, or where the actual angle where you would actually correct it. So we came up with doing minimal incisional surgery of actually doing opposite what we were originally taught, and we make a small proximal incision first over the metatarsal medial cuneiform joint, do our dissection, remove the cartilage, reduce it with a temporary K-wire, which I'll show you some clinical cases of. Usually it's driven from plantar medius dorsolaterally. It's usually a 6'2" Kirschner wire, and then radiographically you can evaluate your reduction of your IM angle. More importantly, evaluate whether there was any elevatus on your osteotomy, and do a push-up test to see that your metatarsals are perfectly level with your adjacent metatarsals. And then when we place our mini fixator on, we try to angulate our fixator because it is a monolateral fixator. We try to make it more parallel to our second metatarsal, or slightly abducted on the distal orientation of the mini rail itself. And when you do that, we find we don't get the cantilever effect when you do compress it, and you won't increase your intermetatarsal angle deformity. The second little trick we do is with the Kirschner wire intact, is we will compress it with the Kirschner wire also, which also prevents any cantilever effect or adduction or increase of your intermetatarsal angle. So by doing all those things, then we'll remove the wire after we actually compress it. A pre-op and then a post-op. And our goals are that we're finding now that probably only about 30 to 40% of our patients actually require a distal incision, a distal bumpectomy, or a distal lateral release. Once you've reduced your intermetatarsal angle, you can see if there's any residual soft tissue contracture, any hallux abductus, and you can do a closed release, or if there's any residual bump, you can actually always go back in and make a small distal incision. So the goals were, this is just a sawbones model of the screws and the fixator from Small Bone Innovation. The advantage of this is it has multiple a turret here and a turret here that gives you multiplanar advantage or multi-positional advantage. Some people will actually put the screws in first and then put the fixator on, and this also swivels right at this area here. My feeling is that the more solid the construct is, the more in alignment of your screws are, the better and more stable your fixator is. The more in alignment of your screws, the less chance for pin irritation, pin weepage, or pin track problems. So what you'll see here in this case is placing the proximal pin in first into the mu cuneiform. This is obviously missing a percutaneous temporary reduction or stabilizing Kirschner wire. But once you place your one proximal screw in first, then you can actually rotate this in the sagittal plane to mimic or match where you actually want to place your first distal screw. I know that some people prefer to put these on top or stacked. I actually find that you get more stability if you can spread or disperse the screws proximally in a parallel fashion. Excuse me. And then once your first proximal screw in is, you can planar flex or rotate or find your proper alignment of where you want to place your distal screw. As you'll see here, dorsiflexing, planar flexing, and then placing your two distal screws in. Once your two distal screws are in, then you can come back proximally and then throw in your final fourth screw into the mu cuneiform. Once again, your temporary Kirschner wire is also intact before you actually compress. That you'll see here. And this is obviously on a solid bone model. I'll show you actually a live or actual patient itself. So just another angle. The screws here obviously from a solid bone are a little long, and these are obviously peeking out a little long too. This is actual patient. This is just a one incision approach. This was actually a revisional hallux valgus deformity where a patient had a distal procedure done previously. She had hypermobility and instability at the first metatarsal mu cuneiform joint and sends forth the recurrence of her hallux valgus deformity. One proximal incision, you see the temporary Kirschner wire driven from plantar media to dorsolaterally. You'll see a self-retaining Wieslander retractor for the exposure for your osteotomy, two distal screws and actually one proximal screw in, and just follow up here. So one small incision here. This is actually 2 days post-op. No distal incision, even though she has a previous cicatrix or scar from her previous bunion surgery, but we only went in and did a proximal incision. And I'll show you the angulation. You want this to be a little more distal, abducted here, and a little more space proximally on this area. Some people say, well, if you put it that close to the skin, you're going to get residual swelling. If you do minimal incisions, you'll find there'll be very little swelling postoperatively. And you always have the ability to adjust or slide your fixator away from the skin further if need be. And also on this patient, I just took this off. We took it off at 5 weeks, 2 days on this patient. And she was weight bearing post-op day number 2 because she had a saphenous and popliteal block of her right lower extremity, so she wasn't able to weight bear till the next day. Moving a little more proximally, Liz Frank or fusions. This is just a case of utilizing 3 mini fixators on the Liz Frank joint area. You'll see that you'll see these screws actually flexing away from your arthrodesis site at the Liz Frank joint area. We usually let these patients weight bear almost immediately if possible, obviously if there is a block or not. The holes usually close up within 4 to 8 hours after we remove the screws and put a dressing on. This is just a removal. But you'll see the 3 scars of lapidus, 1 small incision here and 1 small incision here. So really goals are to minimal trauma to the patient, small incisions, just enough exposure to get to your area of work or concern, in this case just your Liz Frank joint areas. This was kind of an interesting case of just a traumatic episode of man playing tennis, dislocated his navicular. He also had a cuboid compression fracture. The goals were to distract everything and pull it out, and not go in and open it up if possible, utilizing one of the small X-fix screws to help reduce it once it was reduced. And I apologize, I don't know where my post-op is on this, but the patient, I do have a post-op, but I didn't place it in here, and I apologize. This patient had full ankle joint range of motion, was weight-bearing at post-op day number 2, and we took everything off about 5 weeks, 4 days on this patient. This is a acute talar body / neck fracture. A pedestrian was hit by a motor vehicle, actually a drunk driver. The car insurance paid for an MR pre-op. We put on a mini external fixator with longer screws to bridge and have bicortical purchase. The patient was able to do ankle joint range of motion. Percutaneously, this was performed. Pre-op MR and then post-op MR, because the car insurance would allow it, which would be great if we could have that done in a everyday fashion. But I think the one thing that we're doing now, if you're in doubt, obviously x-rays are great. More on the neuropathic patients, we're doing CT scans if we're not sure on our frames if something's completely healed or not. So a CT scan is a good way to go. The cost has come down considerably on these, and it will tell you definitely or not if something's actually healed instead of going to an MR. So I just was trying to give you a small little sprinkling of what you can do with mini external fixators in the foot. Just to review, you have these bullet points that I know this lecture will be archived, but these are the things that we discuss with our patients, and to give them the options. And you'd be surprised at how many of these won't choose internal fixation. And people say, well, you slide it one way or the other by your intonations or tone, but if you go with the monotone voice, which I've been doing for the last half hour or so, you'll find that you'd be surprised at how many will actually go with the external fixators, that you find they like the cosmetic result of smaller incisions. They love the fact that it can weight bear incredibly earlier. Their incisions are much smaller. They're able to bathe earlier, and you'd be surprised of what you can actually do. So going back to the whole shark thing, this is actually a picture from Stinson Beach in the Bay Area in Marin County. They actually do have sharks there. If you're afraid of external fixation, I think you ought to give it a shot. Broaden your horizons, give your patients some more options to choose from. This is my stand-up paddleboard. I'm out on the ocean a lot, and I've overcome my fear of sharks. And this is actually a double rainbow with some pollution in the LA area with a rainstorm. You can see an actual double rainbow, one rainbow here and one right here. So I hope you find your rainbow. I hope that in the short time that we've just spoke that I was able to give you some insight and some options. This is my email address. I'm dating myself with my age that I still have an AOL account, but feel free to email me at any time, or if you have any questions, I'd be glad to answer them now or any time in the near future. Jared?
Okay. Are there any questions that popped up?
Oh, actually, one just came up. So, how important are cosmetic benefits to your patients? When I have this question, I think, we're not all foot models, or are we pertaining that they are foot models? I think, it's not how can I say, a marketing or selling point. Patients just love the idea that their incisions are smaller, and I think we all progressed where, it's a different, what's what I'm looking for, a different attitude that you look at. You have spine guys, for example, that believe in large incisions, small incisions, and, I always like to ask myself, what would I want? And so I think when you say how important are cosmetic benefits, I think people love to have a smaller incision. Smaller incisions usually mean less pain, less scarring or rehab down the road post-operatively. I hope I answered that question sufficiently for the person who asked it. Another question that's come up is how do you prevent the patient from manipulating the rail? That's a good question. If it's somebody that you're doing a callus distraction, obviously you want your patient to manipulate the rail. And one of the things we tell them is that when you do internal fixation, everything is buried in the sand, comparable to an ostrich. You bury your head in the sand. Everything is covered, and you find how non-compliant our patients are with internal fixation. They have a cast on, they can't see it, so they think, it's safe, I'll walk on it. One of the things you find with an external fixator, and that is an important point, is that we actually will tell them, you're responsible for this result, if it is a callus extraction or if it is a deformity correction when the patient's responsible for turning something. And you will actually have to, they're responsible. The easy part's the surgery. The harder part is actually doing the correction and getting out to where you need to be. So I don't know if I answered your question or not, but yeah, I mean, they can easily, we've had patients that have taken frames off or have taken mini rails off, but that's more far and few in between, if that makes sense. There's another question that came up is do you think a radiolucent pin guide holder would be beneficial for placing pins? There's two different thoughts to placing pins. If any of you have done any pin-to-bar things for acute trauma, the goal was you place your screws and you put the fixator on to match or go where the screws are. The other way of looking at it is people do you need a template where you'll actually hold the fixator on, and usually it's a monolateral fixator, not a circular fixator, and in that case you'll use that as a guide itself. I don't know how much. I think in the beginning absolutely a template or a pin guide holder is absolutely beneficial. I think after a while you become more comfortable and you actually use the fixator or the brackets for the guide itself. So the problem is a lot of people, when you have a debate on circular fixators, larger monolateral fixators, or mini fixators, the strength of the product itself. I think the less moving parts you have, the stronger your fixator is. If you tighten down these moving parts, they should be strong. We will use mini rail fixators for calcaneal procedures, that being calcaneal fractures, that being an Evans calcaneal osteotomy. I think they're great for the rear foot, talar fractures. You saw dislocation proximally. I know a lot of people that will actually use it for fibular lengthenings also. So the strength of your fixator is not just the fixator itself, it's also on the placement and the alignment of the screws that you place for your specific procedure.
Is that all the questions we have?
That's all the questions that popped up.
All right. Well, then this concludes tonight's webinar. Thank you, Dr. Wang, for your presentation, and thank you to the audience for your time and participation. Tonight's event has been recorded and will be available for future viewing at www.totalsmallbone.com. Have a great night, everyone.
Thank you.